My name is Carola Zillekens from Rotterdam, the Netherlands. We have three very distinguished speakers today: Dr. Appelman Dijkstra from the Netherlands, Dr. Alexandra Ertel from France, and Dr. Francesca Marina from Italy. The session will take approximately 45 minutes of presentations with lots of time for questions and discussions for the audience. So please do remember to ask your questions throughout using the Q&A button. And questions will be discussed after all presentations during the dedicated question and answer time. If you have any IT, technical or other problems, please use the chat button and contact the ESE team who will be able to help. This session is being recorded and will be available on the ESE website in approximately 2 to 3 weeks. And then we'll start with the first speaker, Dr. Natasha Appelman Dijkstra. She is internist endocrinologist specialized in bone and mineral disorders at the Leiden University Medical Center. And she's head of the Center for Bone Quality in Leiden. And she participates in EuRR-Bone and endo-ERN. Her research focus is centralized around the care for patients with rare bone and mineral conditions, with a special focus on fibrous dysplasia and McCune-Albright. She is a project team member of the European Registry for Rare Endocrine Conditions, and she is the coordinator of the European Registry for Rare Bone and Mineral Conditions, EuRR-Bone. Natasha, please go ahead and enlighten us about the EuRRECa registry.
Well, thank you very much, Carola, for this kind introduction. In the next couple of 15 minutes, I'm going to talk shortly about EuRRECa and EuRR-Bone registries and how to use it. The main purpose from this talk will be a practical introduction, because the two later speakers are going to expand a bit more on detail on the various topics that you can report on. First, some information about the evolution of EuRRECa and EuRR-Bone. It might not be known for everybody, but in 2016, the European Committee founded the European Reference Networks for Rare Endocrine and Rare Bone Diseases. And from 2017 onwards, already the first registry, EuRRECa in this case, was approved. EuRRECa was built as a registry to cater the needs for endo-ERN, so the European Reference Network for Rare Endocrine Conditions. And the next following years, EuRREC, our short electronic reporting platform, was launched. And afterwards, a year after, the Core Registry was also launched. In 2020, the EuRR-Bone was approved, and EuRR-Bone is a registry for rare bone and mineral conditions, which serves the needs of EuRR-Bone as well as part of the needs of endo-ERN. And part of EuRRECa and EuRR-Bone are the condition-specific modules on parathyroid carcinoma, but also on rare hypophosphataemia, where the later speakers are going to talk about. So in the progress of time, EuRR-Bone and EuRRECa were originally funded by the EU and are now more and more incorporated into the European Reference Networks as Work Package number 5. And this means that we will have ongoing funds for the coming years to continue our work on this field. So why do we always talk about EuRRECa and EuRR-Bone? Well, there are two different projects because they were based, of course, serving the needs of different ERNs, but they have one purpose. And for that reason, we also made one back office. So like I said, they cater the different needs and also involve different stakeholders, like for EuRRECa, SP and ESE is of course a very important stakeholder. And for EuRR-Bone, we also try to connect with ECTS and ICSBH. In our current approach, by combining the two projects, this allows us a wider range of versatility through a low-cost platform because we can build everything ourselves and cater the needs of our stakeholders in a better way. We ensure long-term sustainability because this platform is versatile and we can combine forces. And also we can collect a large quantity of patients and quality indicators of care. Also, because we have a broad platform with many patients involved, this facilitates new patient involvement because it's easier also for patients to get connected and to learn more about the registries and what's useful for them and what's not. So for the registries, we have different levels of participation. First, we have the EuRRECa platform, which is a electronic reporting platform of rare conditions. And this is mainly done by the clinicians. So this is only a counting platform, which means whenever there is a new case seen, for instance, in this instance here, you see in OI or McCune-Albright syndrome, you can say, well, I have seen 1 or 2 children or perhaps adults, and then you can just submit that as a counting case. This does not require informed consent of the patients, and we merely count cases of patients. It gives us an idea on where the HCPs, so the healthcare providers, are who see a lot of patients, and it can also, in the end, help with getting some sort of much more knowledge about the epidemiology of a disease. So at this case, current cases, we have till December 2022. This is the map of the reporting centers throughout Europe. As you can see, we have 66 centers who are actively reporting from 22 countries. Among them, a lot of them are EuRRECa or EuRR-Bone members. However, you also do see that we have 17 centers who are not affiliated to either, because in some cases, it might not be able for participants to be an EuRR member, but you can still contribute to the registries. So you don't have to be a European Reference Network HCP to help us collecting data. So the next level of participation is the Core Registry. The Core Registry is available for clinicians and patients because there we collect generic outcomes like EQ-5D, but also other prompts are being collected there. But also we collect a common data element set, which was mandatory for the EU registries to start on. The common data element set is a small set of elements where we collect things like diagnosis, onset of complaints, definite diagnosis, but also if the patient is alive, yes or no, and also if there was any patient delay or doctor's delay in setting the diagnosis. We also collect if patients are already part of a detailed disease registry to refrain from over-reporting, and if there are any biobank samples available for future projects. And the next level, also part of the Core Registry, are the condition-specific modules, where we have a specific set of conditions where we're already collecting more than only the generic outcomes, and these will have more attention later onwards. So at this moment, we have 21 centers already reporting into the Core Registry. As you can see here, because this requires informed consent, it usually takes centers around a year to get everything started, and therefore the map is less colored than with the EuRRECa platform, because it's much more easy to do. We also there have HCPs who are not affiliated to either of the EuRRECs or none of the EuRRECs. So again, I would like to emphasize this is an open platform, open for all, and patients can HCPs can easily participate. To date, these are the disease-specific modules that we're currently hosting. Some of them are initiated by EuRRECa, which are stated with under the MTGs, the main thematic groups from the EuRRECa, and others are instated with EuRR-Bone, and we have one that is in collaboration with ECTS on melioidosis. The latter one started in 2023. Pediatric differentiated thyroid carcinoma is at this moment under construction and is expected to launch soon. So now the practical part of my talk. So this is our website, and from that website you see the access button, and by the access button you can choose which platform you want to report on. So this is the EuRRECa platform, which opens with a username and a password. And there you can find also a dashboard which states your previous returns. So as you can see here, we're already reporting for a longer period of time. And if you want to find out on how many cases you've seen for a certain disease, you can now download multiple returns at one time. So for instance, if you need to produce some numbers, you can easily find them back in the system. If you want to change your reporting setup because you want to start reporting on new pediatric cases or new diseases that have been seen in your HCP, this is the way to do it. And you can always change it for every time that you do it. In our platform, you will see the possibility for producing suspected cases, but also confirmed cases. And if you have reported a suspected case and you are still awaiting some tests or genetic testing, which of course can take a while, you can later on come back with the same idea and then turn your confirmed case or your suspected case into a confirmed case, or say it's not confirmed and then it will not be entered in the registry anymore. This is also something you can easily do. Now, from the same button, we go to the Core Registry, which has also access with a password, but also with a two-factor identification with the OTP. If you have problems with that, we can easily help you set it up, and then you can automatically come into this dashboard. In this dashboard, you can see the centers that are registered in your center, the patients that you have been registering, but also if you're the center lead, you can see also how many patients are being registered by other clinicians in your hospital. There's always one center lead in a center because the center lead also has some administrative functions, like the center lead is able to delete cases if requested, or if people have done test cases in it, you can also delete them. In this dashboard, you can always see which conditions you're reporting and if they are pediatric cases or adult cases. Here I show you the overview of patient access. We have different levels of patient access. And in this case, you can also see if there are any patients who have a deletion of their account requested, but in this case, it's not. So these are the setup for the common data elements. And also you see we have a dynamic consent form, which can easily be changed. And also the patient is able, when they have granted access by the clinician, to change their consent, for instance, for newsletters, or if they want to be contacted for research purposes. If you've saved the data automatically, you can always come back to a certain part of the registry and start. So here you can see part of the diagnosis, but when we go into the depth to the diagnosis, in this case, pseudo-hypopara, and then you can select the different ones of the condition and save it successfully. Once you've saved it and you have granted your patient access, you will be able to put in the patient's email address, and you can set up an email explaining to them that these are the information they need to set up their own account. And if you can see in the next box, you will also see that we have translated the platform in different languages. So if you miss a language, please let us know, because then we can adapt it to the registry as well. If we then go to generic outcomes, we have a fixed set of questionnaires that are available for you. So the EQ5D, available in many languages. You can choose the language and then set the outcome rate for the patient to fill out. We have the brief pain inventory, which can also be done in the different translations, which are all validated translations for you to use. And if you press new outcome, you can set up, you saw the overview, what you see then. If we proceed into the condition-specific module, like here, pseudo-hypopara, you see that it's diverted by several tabs, which contain a clinician-reported outcome set, which are developed by the various study groups on the different diseases. Again, if you look at the diagnosis-specific outcomes, we have certain items that are available, and these might be different in different cases. And I think it's very important to know that these outcomes are not mandatory fields. So you can always start with filling them in and come back later to finalize them. To use the questionnaires, it will also be very useful, of course, to get them in your own patient file as well. So we have now made it the possibility to download the outcomes of the questionnaire so that you can download them and use them for local research perhaps, or just to upload them in your electronic medical file. So you can use the outcomes as well in your current daily practice. They will be downloaded as an Excel file. If you want to look one of your patients up, you can always go back to the patient list and then select the patient also by the dashboard. And we have a new issue there as well with patients with outstanding actions. So whenever you try to start up a data collection and you go to the patient record, you see that little button over there, which is an added to-do box. So if you are actively doing something, or you have a student or a nurse to help you, and there's something missing, you can add a little note there and save it, and then the box will turn on red. And if you go back to your dashboard, then you will see that there's an extra patient with outstanding action. So that's just to make everything more easy and more easy accessible. A lot of the things that we have been doing and have been changing most lately are based on user experiences. So if you're using the registry and you're missing something, please let us know. So to summarize the registries in one slide, which is quite a challenge, but I'm going to try it anyway, is that if you see a patient with a first encounter, so new patients in your hospital, you don't need informed consent just to put them in the EuRRECa platform, because we're just counting numbers. If you are seeing patients for any encounter, you do need patient consent, because then you can put them in the core registry, and if available, you can put them in the condition-specific modules. What we didn't touch upon, but it's good to mention, is that we have a project management team in place, a steering committee. We have a data access policy and data access committee, and you can find all our information on the website. So for further information, you can find it on our website. We have online drop-in sessions via Zoom every second Friday of the month and every fourth Wednesday of the month. And you can see the big button also in our new website. And if you have other questions related to the registries, just drop us a note on registries@lumc.nl, and later onwards I will be open for questions.
Thank you, Natasha, for this overview of the history of the creation of these registries and for the very clear practical information on how to use them. Thank you very much. People, as mentioned before, can post questions in the Q&A box, and we will come back to them later. Thank you, Natasha. So then I'm very happy to introduce the second speaker, who will talk us about XLH and the registries, and this is Alexandra Ertel. She is a pediatric endocrinologist with a special interest in growth diseases and bone and mineral conditions. She was trained as a general pediatrician and pediatric endocrinology at the University of Vienna in Austria, and she was an ESPE clinical fellow at Beatrice Paris-Saclay Hospital in France, and got involved in the registries EuRRECa and EuRR-Bone under the lead of Professor Agnes Linglar in the development of condition-specific modules for example, pseudo-hyperparathyroidism and hypophosphatemia. And since 2022, she's working as a senior research scientist and pediatric endocrinologist at Beatrice Paris-Sud Hospital in Paris, and at the Reference Center for Rare Diseases of Calcium and Phosphate Metabolism, Oscar Villiers. I hope I pronounced it well. And Alexandra, I'm very happy to give the floor to you and hear your presentation.
Thank you very much. So I will try to start by presenting you some data on what we got from EuRRECa and from Core Registries regarding the rare mineral conditions on the first part of my talk. And then in the second one, I will concentrate on the module which we generated for rare hypophosphatemic disorders. So if we take a look at this chart, we can see that we have some conditions like hyper or hypo parathyroidism, which are really good represented in EuRREC, but also other conditions like X-linked hypophosphatemia or other causes of hypophosphatemic disorders in both suspected and confirmed cases. If we look on the evolution of the reporting in EuRREC starting 2019, already in October 2022, there were more than 700 cases of mineral conditions recorded in EuRREC, coming from 48 centers. And if we take a look up to March this year, this number increased to 41 reporting centers and more than 900 cases of patients. Down at the bottom of the table, you can see for X-linked hypophosphatemia, for example, we have a pretty large amount of reported cases, suspected or confirmed. The trending of reporting, it's pretty much similar as what we saw in every registry for every rare condition, with a slight go down trend during the COVID times. But we can see that we have a positive upwards trend since 2022 for both confirmed and suspected cases, and especially with this peak in the first part of this year. If we take a look only at XLH in EuRREC, we can see a predominance of the pediatric cases which are being reported. But of course, we still have to wait for the end of 2023 to see if this tendency is still stable. But with this occasion, we would like to encourage our colleagues which are seeing the adult patients to report cases in EuRREC. If we take a look at the reporting countries and the number of patients which were being reported and the numbers of centers, we can see that we still have some potential in increasing the reporting in EuRREC. If we go to the Core Registry, which Natasha explained before in what it contains, and we see again the representation of most of reported rare mineral conditions. We see that 56 patients are reported with hypophosphatemia, and from them 47 are diagnosed with XLH. Of course, the number of centers which are reporting in Core Registry is way lower than the one which are reporting in the EuRREC. And the XLH patients, as I said, the predominance for children. Here you can see the countries which are reporting and the number of patients reported and the number of centers. And of course, even less countries are reporting for XLH at this moment. It's only 7 countries and 8 centers. So also here, a lot of potential for collecting data. So in terms of what we noticed in the number of patients reported, there was the idea to expand the data amount in the Core Registry and to create a condition-specific module, which was developed by a study group, which we created, the Rare Hypophosphatemia study group. And we intended this module to be available for both pediatric and adult patients. We have met several times and we decided on which parameters to use. A beta version was built and then tested by the members of the study group, and the version went live this year in January. So it's a rather new condition-specific module. This is the composition of the Rare Hypophosphatemia study group at this time. As you can appreciate, it's a very multidisciplinary group. with specialists from both pediatric and adult endocrinology field, but also patient representatives and pediatric orthopedic surgeons and rheumatologists. The diseases, the disorders we decided to place into this group of rare hypophosphatemic disorders you can see listed here. And as Natasha mentioned, you can also go to the website and find more information in the data dictionary. So we started, we addressed this issue in how to create a module in terms of feasibility. And we decided to create a basic disease module, which will address only the two parameters. So the two windows which you see on your screen for the clinician, which doesn't have enough time or enough finances to ensure a more detailed data collection. We do intend to cover data from the diagnostic up to the care, medical care pathways for these patients, so both pediatric and adult. We also recommend to use parallel to this basic and to the extended version of the module, the PROMs, so the patient-reported outcome measures, which the ones which we selected for our group, for our modules, you can see here. So we would intend to have a feedback from the clinicians every 2 months for adults and every 6 months for children, which so in general patients which are seen on a regular basis. But of course, each clinician can put in data at the time of each visit, because it offers him a really nice overview of the most important parameters that and factors that you look at when you see a patient with XLH. So what improved, for example, since the last visit. And for the extended version, we selected factors, so parameters, which are better defining the clinical, the genetical, the radiological background of the patient, and of course its evolution over time in matter of treatment. So here, for example, the genetic findings, you have the possibility to better define the patient in terms of what mutation was found. The family and perinatal history of importance, of course, the pediatrician, most of all. The clinical findings, current meaning, for example, at a certain visit, when you see the patient in your outpatient clinic, you can select some of the most known complications which might appear during the follow-up visit, dental status and the findings you might find. Of course, we give the possibility for some radiological parameters to be also collected. And if you might encounter some issues in understanding what we mean by, for example, level of lumbar stenosis, you can use the question marks, which will lead you to the definition of this parameter. The biochemical findings, we know we went for a long list, but they're all important factors. It's up to the clinician to fill in the parameters which he or she finds to be useful for their follow-up. But of course, we would prefer that as much data on XLH would be collected using this module. If you do some other investigations in your center, which are not routine, you also have the possibility to place them in, like a brain MRI, for example. The medication, the therapeutic plan is very important. We try to cover up the most used medical approaches. and also address the pain medication. Of course, the surgical interventions, which are not something to be ignored in this group of patients, with the opportunity also for the orthopedic surgeons to report data on their patients. And regarding PROMs, I really have to salute the work which we did in the study group together with the patient representatives, because this came from them, this recommendation to use an oral health questionnaire. So we also added this to the PROMs, and it's really easy to be filled in by both clinicians and patients. So for the future, we would like to go on promoting this module, which is the still young module. And the team of EuRRECa and EuRR-Bone is doing this nicely with the newsletters. Of course, the patients' organizations are also really involved, from at least for this group of disorders. We also appreciate every chance we have, like webinars like this, where scientific societies are really interested in what's going on in the registries, and of course the social media platforms, because awareness is really important for data collection. We would like to change positively the data collection trend. We see already the tendency going upwards. So we really hope that you clinicians and the patients will be interested in helping also us improving the module on one side, and of course for the future to improve research in this field. If you have research ideas, if you want to start research cooperation, contacting the team and the study group is the way to do it. So I would like to thank the project management team for organizing all the meetings, and for the technical support, and for all the great work that they did. Of course, the experts in the study group, which found the time to meet, all the reporting centers, clinicians, and of course the patients.
Thank you, Alexandra, for this very clear presentation. It's very good to see what kind of questions have to be filled in for this specific module. And we'll come back later with questions in the Q&A. So thank you very much. Then the last speaker of today is Francesca Marini. She's filling in for Maria Luisa Brandi. She had her master's degree in biological sciences, magna cum laude, at the University of Florence, in Florence, Italy. And she did her PhD degree on clinical and experimental medicine at the University of Florence. She is working since 2001 in the research group of Maria Luisa Brandi, first at the University of Florence, and from March 2021 at the Fermo Umlus Foundation, the Italian Foundation for Research on Bone Diseases. She has a focus on genetics, epigenetics, and molecular biology in the field of multiple endocrine neoplasia, parathyroid diseases, and rare disorders of bone and mineral metabolism. Francesca, please enlighten us about the module on parathyroid carcinoma.
Thank you. Good afternoon, everybody. I will introduce the recently created registry on parathyroid carcinoma. And first of all, a brief introduction of what parathyroid carcinoma is. So parathyroid carcinoma is a very rare malignant tumor of the parathyroid glands that accounts for less than 1% of all primary hyperthyroidism cases in Western Europe and North America, and with an incidence higher in China and Japan. Commonly, the disease is sporadic, but familial cases are reported both in syndromic or non-syndromic endocrine disorders. It's a malignant disease with a poor prognosis, and because of a high recurrence rate and the manifestation of local and distant metastases just at the time of diagnosis. The pathogenesis of the disease is complex and is not clearly known at the moment, but we think that it is an interplay between both genetic and environmental factors. The biallelic inactivation mutation of the CDC-P23 tumor suppressor gene encoding for the parafibromin is the most common genetic defect that was found both in sporadic and congenital form of the disease. And on the contrary, is very rare in the benign parathyroid adenoma. So maybe it's a mark of malignancies in this kind of tumor. Recent studies using wide genome sequencing on wide exome sequencing or transcriptome analysis, proteomic analysis, and analysis of epigenetic factors or mRNA, long non-coding RNA, and circulating RNA evidence that there may be some pattern specific of this kind of tumor, differentiating it from the benign adenoma or by the normal gland, but they are to be confirmed in more studies and in more cases. The diagnosis is still a challenge. It's difficult because clinically the disease overlap with adenoma, overlap with hyperplasia, and the diagnosis is still made on the surgery setting and in the post-operative analysis of the resected sample by the pathologist. And usually is made by the finding of an invasion of local tissue, invasion of vascular tissue, and the presence of lymphnodal or distant metastases at the time of the surgery, or mostly during the analysis of the resected tumors, in which pathologists have to find usually 4 or more features of malignancies to define the presence of a malignant carcinoma. But it's just a challenge at the time, and is in many cases is operator dependent. The clinical presentation is quite typical. Usually, the great majority of patients have symptomatic complication of a severe hypercalcemia. The level of PTH in the serum are very high, up to 10 times upper the limit of normal. The involvement of kidneys and skeleton is common, with the presence of reduction of renal function, with the presence of nephrocalcinosis, nephrolithiasis, and osteoporosis, in some cases associated with the fragile fractures. Patients may manifest hypercalcemic crisis, and 2 common hallmarks of the presence of metastases just at the time of the first diagnosis of the tumor. 50 to 30% of local metastases at the lymph node of the neck, and about 30% of patients have metastases in lungs, liver, brain, and bone at the time of the first diagnosis, and so they have a bad prognosis. However, given the extreme rarity of this disease, it has been difficult to date to have a clear overview of the disease, and we don't know an exactly epidemiology analysis of the disease. We don't know exactly the aspect of the molecular basis of the disease, and most of the natural course of the disease is unknown, and at the moment we are not, we don't have a clear view of what are the factors that determine a bad prognosis in some patients and not in others. So we have few data about this rare tumor, and they are mostly derived by single cases, few case series, that are limited to monocenter retrospective studies, or they are derived from the retrieval of data from database about general cancer forms. And so we know that we have a great need of creation of dedicated registries to collect specific data about parathyroid carcinoma, with a special focus also on the follow-up of the disease and what happened after surgery, after treatment. And in this slide, the parathyroid carcinoma study group, you can see here the members, and we involve also the patient representative to enlarge our knowledge about this disease. Decided to design and to create this parathyroid carcinoma registry within the EuRRECa program. The registry is quite novel. It has been created between April and November 2022. And you can see here a list of data that we aimed to be collected inside the registry. They are general aspects of clinical presentation of the disease, data about diagnosis, including genetic testing, including imaging of the neck, including biochemical screening of metabolism of bone and mineral diseases, including a check on the both health and the function of the kidneys. And then we include treatment used prior and after surgery, and data about surgical intervention and what happened to patients after the surgery, both in terms of screening, constant screening of the neck and of the function of parathyroids, and the presence or occurrence of persistence and recurrence of the disease. The registry was finalized in its final form at the end of November 2022, and it is working at the moment, so you can insert your data. Currently, 5 cases have been collected in the registry. And just rapidly, how to access the registry, and Natasha said to you, you have to register to the EuRRECa platform to obtain your personal credential, so you can enter by your username and password, and then every time you enter, you receive a temporary code on your mobile device. So you enter this section, that is a general section in which you can add patients in all the EuRRECa registry. You have to select calcium and phosphate disease to insert parathyroid carcinoma cases. And then you access to the second page in which your patients receive an anonymous unique code by which you can insert your data, not only in one single time, but you can reopen the patient's schedule, and you can insert data, update your data every time you want, every time you need. And then to enter the parathyroid carcinoma registry, you have to select as primary condition hyperparathyroidism, including parathyroid cancer. And then you have to select as specific diagnosis parathyroid carcinoma. So you enter the parathyroid carcinoma registry, and you can see here it is composed by 10 sections, in which you have a general section with demographic data of the patients, in which you have to report the clinical history that prior to the diagnosis of the parathyroid carcinoma included the surgery and included the medical treatments patients underwent. Then you have a small section dedicated to the history of neck irradiation before the diagnosis, and a section of family history of parathyroid carcinoma, in which you may report the first degree relatives that occurred with the parathyroid carcinoma. Then you have a second section, that is the diagnosis section, in which we have a general part about the symptoms and the clinical manifestation of the disease, including burn, pain, and affection of the skeleton. And then we have the evaluation at baseline of serum and urine parameters of parathyroid function, bone and mineral metabolism, and the function of the kidneys. Then we have part dedicated to the genetic testing, in which you can report all the genes that have been analyzed in your patients with the identification or not of a mutation and the clinical significance, if you know it. And then we have a large part of the database that is dedicated to the imaging analysis of the neck prior to surgery, which we included. You can see for all the analysis specific features that could be assessed. In this case, you have data about the macroscopical and microscopical characteristic of the nodule. If the lymph nodes are affected by metastasis and so on. This is the neck ultrasound, but we have also a part about parathyroid scintigraphy, PET CT scan with choline, neck CT scan, MRI, and two PET CT scan with positron emitting molecules. And a part dedicated to the analysis of bone health before the parathyroidectomy. And so we have a second part, another part dedicated to the medical treatment of the disease. This one is related to the pre-operative treatment of the disease. So in cases patients have been treated with cinacalcet or other drugs to control hyperparathyroidism and hypercalcemia. And you can register also the occurrence of adverse event to the treatment. And this part is dedicated to the surgical intervention and ablation of tumors. You can report the type of surgery patients underwent, and you can include if lymph nodes were resected and in which parts of the neck, and if you have a short-term complication after surgery. And important, we put this thing that is related, that if the surgery has been performed in a local center or in a specialistic center for parathyroid surgery. And then this is a quite complete section dedicated to the histological analysis of resected tumors and lymph nodes that comprises all the features of malignancies and some specific immunostaining that are performed to check if this is a parathyroid carcinoma. For example, cyclin D1, immunostaining of P27 protein, and immunostaining of parafibromin, and so on. And then we have a subsection, small subsection about tumor staging, and this has been done using the common tumor staging for tumors, because a specific tumor staging for parathyroid carcinoma at the moment does not exist. And then another part dedicated to if you have performed genetic analysis at somatic level on the resected tumor, including the assessment of allelic loss at this locus that contains the CDC72 gene that is commonly deleted in parathyroid carcinoma. And then we created a part dedicated to the post-operative follow-up of the patients, in which we have a part of the short-term post-operative assessments of the restoration of normal calcemia and restoration of normal secretion of PTH. Then a post-operative clinical follow-up focused on the presence or not of persistence of disease and development of short-term recurrence after surgery. And here we have the post-operative biochemical test. So the first one, if possible, the first one done, the first one made after the surgery, in which we have the same parameters that we have measured before the surgery, including parameters of parathyroid function, parameters to check the correct bone and mineral metabolism, and the functionality of kidneys. And I show you just recurrence 1, but we have 3 sections that are recurrence 1, recurrence 2, and next recurrences, in which you can assess the follow-up controls of the patients in long-term, even long-term follow-ups, in which you can assess the presence of disease recurrence by analysis of calcium, PTH, loss of functionality in the kidneys, long-term post-operative complication. If the patient has been treated with cinacalcet or other drugs for the treatment, for the control of the recurrent hyperparathyroidism, and a section dedicated to the assessment of recurrence by imaging of the neck. So you can see here all the techniques that we insert in the registry. And finally, the last one, we inserted also the possibility to have a questionnaire checking the quality of life of patients that have to be filled by the patients with the help of the clinician or alone, in which we want to check specifically the quality of life related to hyperparathyroidism and hypercalcemia. And the questionnaire could be performed both at the time of primary cancer and repeated in case of disease recurrence. So this is a general overview of how we structured the registry. The registry is working at the moment, so you can register yourself and insert your cases. And thank you, Natasha. Thank you all the group of the EuRRECa for the opportunity, and thank you to all of you for the attention.
Thank you very much, Francesca. This was very clear. Good to see what has to be filled in. What is your experience on how long it would take to enter the data of one patient?
It depends. It depends on how many data you have available, but not so much. I'm not a clinician, so every time I insert data, I'm together with my colleague that is an endocrinologist. But usually we work 2 persons, one insert and one read the medical record of the patients. 30 minutes, 20 minutes, it depends. Depends on how many data you have, how many analysis you have to check, but it's quite easy. You can.
It seems very logical. Yeah.
The good thing is that you can stop whenever you want, and you can return again inside the registry and update the data. So if you have 10 minutes, you can insert some data and then you can go back later without problem. So it's it's
Thank
easy.
you very much. The questions are very clear. We have a few questions in the chat, and please, everybody, we welcome you to pose your questions as well. There's one important question, I think, by Agnès Lignard, is how can we increase the number of physicians and centers enrolling patients? I don't know who of you might want to comment on this, maybe Natasha, but also maybe Francesca or Alexandra. What are your suggestions? How do we get more involved?
Yeah, I think it's a very good question because we have been debating that a lot lately, of course, more in general. So one of the things that will automatically make sure that we enroll more patients is the fact that EndoERN has decided to switch to the EuRRECa as the platform to get their returns for the HCP monitoring from the ERN. So in the next couple of years, they will fully switch to EuRRECa. But then again, the thing that is of course very interesting for us as clinicians, as researchers, but also for patients are the core registry and the condition-specific modules. So from our coordination team, we're now engaging with all the different study groups, like the parathyroid carcinoma study group and the Rare Hypophosphataemia study group, to see how we can help to improve it. And I think that that's really something to hear your opinion as well, Alex, on setting some goals, because that's one of the main questions that people ask us. Yeah, how many patients do you want to enroll in the registry? So I think it would be good for the study groups also to have some sort of virtual endpoint for a first interim analysis. So for fibrous dysplasia, we have set that on March next year. We want to include at least 100 to 200 patients and then do our first interim analysis. But that can be different, of course, per hospital.
Yeah. Natasha, if I understand correctly, in the EuRRECa, you only enter new patients, right? So the patients that are already in treatment, you never enter them in EuRRECa, or did I misunderstand that?
No, so it's only the new cases. So you don't have to enter all your control patients. For your control patients, we prefer you to ask them for the core registry and its condition-specific modules.
Okay. Thank you. We have a question which I think is very relevant by Lars Wijnmark. He says, presumably this will also be used for scientific purposes, and will all investigators who have contributed with cases become co-authors on the papers? Do you have rules for this? I think this question is also for Natasha.
Yeah, that's also one of the questions we've been asked quite a lot. So we have put out our rules for co-authorship on the website. But yes, we involve all reporters for the different conditions in the manuscripts, but also in the abstracts which have been sent to the various scientific meetings. We're still, because of course there are not 1,000 reporters at the moment, so we're still able to include everybody in there. So yes, so if you try to enter patient data, you definitely will also be contacted when we do something with it.
Okay. I have another question, but first one question I think I can answer with yes. Is it possible to register as a new participant? I think the answer is yes, correct? Okay.
Absolutely.
Then the last question, how often do you ask reporters to add or update data? Is that different between the different modules? How often do people have to update?
Yeah, so we have also per module, there are some different, not really rules, because of course this is a natural history, and of course we're fully dependent on the time people want to spend on putting in data into the registry. So we don't make anything obligatory to do, but for instance, for some modules we have set it at least once a year. And for pediatric population, at least twice a year, and yeah, more if needed or if desired. So we try to be a bit more flexible. So we have set a lower limit, but you can enter data as much as possible.
Okay, very clear. So I think this was a great meeting. We've learned a lot. I'm going to close the meeting. I would like to thank, of course, all speakers for the very clear presentations, and thank all the attendees for attending. And we look forward to seeing you at another ESE event very soon. Goodbye, and thank you very much.
Thank you.
Bye.